Hey everybody, it's Dr. Rick Rosenfield here at the Pearl Women's Center with Dr. Erin Conlin. We are going to talk today about a topic that is very near and dear to our clinic and especially to Dr. Conlin, and that topic is
menopause.
Menopause. Yes, absolutely. So we're going to do a little bit of an informational video, conversation style. It seems to be a good way to go. We've had a lot of inquiries coming through our website about menopause treatment and how we handle those things here at the Pearl Women's Center. So I thought we would kick it off just by defining what exactly is menopause. So why don't you go from there, Dr. Conlin?
Yeah, menopause is one of my favorite things to talk about, so I'm really excited to do this video. Menopause is actually defined as 12 consecutive months without menses. The average age of menopause in this country is 51, but that means some of us fall before then and some of us fall a little after that.
And it's interesting because, you know, lack of menses would also be considered, even though it's the actual definition. What about a woman that is younger but has a hysterectomy but still has functional ovaries? We always get questions about that. Is that patient in menopause? Well, surgical menopause might be a little bit different than, you know, natural biologic or physiologic menopause, which is really what we think about as when the ovaries stop firing off eggs to get pregnant. And that's when hormone levels will change, and which is a great segue into explaining what are the hormonal changes that occur in menopause, and when does that typically happen? Like, is there an age range? Is it a particular age?
Yeah, great question. So we do see lots of shifting of hormones in perimenopause. So perimenopausal symptoms can happen, 7 to 10 years before actual cessation of menses. Those symptoms can last about that long as well. We typically see really irregular hormones in general. So that's actually the hallmark of perimenopause. We can check your hormones and we might have estradiol here one day and the next day down here and the next day back up. So we have really irregular hormones.
And you mentioned checking them. So there's different ways of checking hormones. I believe that your preference is with the blood serum level. Is that correct?
Yeah, and I typically don't check perimenopausal hormones, but we can do that after menopause, and sometimes we do that to manage hormone therapy.
And I sometimes describe to my patients, that the way that this works is that it's really the communication between the brain, which is the pituitary gland, and the ovaries, which are in the pelvis of a female, and then the uterus. And so there is a communication that occurs that really allows a woman to have a menstrual cycle. So the brain kind of yells at the ovary, hey, let's get pregnant, right? And hormone levels rise. That first rise would be follicle stimulating hormone, which leads to a rise in estrogen. And then at a certain level, we see ovulation. And then after ovulation occurs, there's a rise and fall of another hormone, which is progesterone. And when progesterone levels drop, the menstrual cycle begins, or the actual bleeding of the menstrual cycle begins. And so as women age, and you don't get more eggs, right?
Nope, so they're locked in two little vaults, and we do not know how many are in there.
So you're born with the most number of eggs, and then at that point in time, they start to decrease every month. And so when the egg quality and the egg number start to deplete, your brain has to yell a little louder to try to ovulate. So we see that FSH numbers go up. And that usually is kind of the definition, at least with lab values, right, of menopause. So when your FSH level goes really high, that's an indicator that your ovaries are no longer responding. So patient comes in, having some irregular cycles and is interested in ruling in or ruling out menopause. What are some symptoms that you see in patients that come in with menopausal questions?
Yeah, so the hallmark most of us know are hot flashes. So hot flashes and night sweats, irregular bleeding, mood changes are super common, so anxiety, some low moods, sleep troubles, vaginal dryness, joint pain, eye dryness, many different symptoms.
It's a long list. It's a long, and a lot of this will be on our website as well, of course. So doing an assessment of symptoms, and then also I think understanding what lab values really represent. And this is a really exciting thing, I think, for us, because it segues into this concept of what functional medicine really is. So there's this idea, when I was trained in medical school, of, here's a lab value, and this is normal and this is abnormal, but normal oftentimes has got a pretty big range, right?
Right.
So this idea, if you look at a normal lab value and there's like a bell curve of, this is all considered normal, it's unlikely that somebody's going to feel exactly the same if they're at the low normal versus the high normal of any of these hormone levels.
True.
So I believe in naturopathic medicine, there's definitely a bigger and more significant approach to how we manage these things. Would you agree with that?
Often, yes, and specifically with things like thyroid and a non-hormonal lab that falls in that same category as ferritin, looking at iron storage.
So if a patient were to come in and was, say, perimenopausal, so within this maybe 10-year zone of hormonal changes, what are some of the ways that you work with patients to help them feel better and maybe kind of optimize their wellness?
Well, I first sit down and we have a really comprehensive conversation. I do love to spend a good deal of time with my patients and really understand their history and where they're coming from, and then really understand what symptoms they're experiencing and the progression of those symptoms from the beginning of their perimenopausal time moving forward. And then we go through and we make sure we're doing some screening labs. With onset of menopause, we know that there's potential increased risk for development of cardiovascular disease, so we check in some of those parameters as well. We always want to check in on your thyroid to make sure that some of the symptoms that you're experiencing with change in menses is not related to just thyroid.
Right.
So we really like to take a step back and look at you as a whole person and really take into account all of the pieces of the puzzle before we just head down one path.
Okay. So let's talk a little bit about hormone therapy.
Sure.
So there's different ways that people can be prescribed hormones, and there's different ways to take hormones.
Yeah.
What about the patient that comes in and says, I heard that hormones are bad. I heard that they're dangerous.
Love to have that
Let's
conversation.
talk about why hormones are not bad, or is there a difference between good and bad hormones, like synthetic versus bioidentical?
So in 2002, the Women's Health Initiative was actually stopped early. The Women's Health Initiative was a $1 billion study, probably the largest study we will ever have on hormone therapy and menopausal symptoms. It was originally conceptualized to evaluate impact on cardiovascular health. The study, like I said, was stopped early because it appeared to have an increased risk for development of cardiovascular disease and also breast cancer.
And when you say there was a risk, you're saying in women that were prescribed hormones,
That's
there
how
was
it
there was a thought
Yeah.
that possibly these hormones were bad.
Right.
And I remember because I was working at a big clinic at that point in time. I was actually working at Kaiser Permanente, and I remember there was a flood of phone calls. Like patients were panicking.
Millions of women went off hormones. Millions of women's lives were negatively impacted. It's been 19 years. We've had plenty of time to look back at that research and evaluate subsequent research and say what actually was happening there. So we know that the average age of women in that study was 63. But like I said earlier, the average age of menopause is 51. So there's a tremendous difference that happens within the female body between age 51 and 63. We now have something called the timing hypothesis, where we understand that the timing of initiation of hormone therapy is actually crucial. There are changes that happen within the cardiovascular system that if we later add estrogen in can be quite problematic. So in those women who had gone 10 or more years without use of either hormone therapy or at 10 years past their last menstrual period, and then they were given hormones, they did have an increased risk for development of clots and strokes.
Right.
So in those
So the
women,
delayed interval was probably the problem.
that was very, very likely.
And I think there also may have been an issue with the type of hormones.
Yes, so the type of hormones that were used were all synthetic. So Premarin being the synthetic estrogen and then synthetic progestins as well. We now have a better understanding of how those hormones worked. In the WHI study, women who were divided into two different groups, and this is classically how menopausal research is done. So those with a uterus and those without a uterus. If someone does not have a uterus, we do not have to give them some sort of progestational agent like synthetic progestin or progesterone. Estrogen is kind of like a builder, and it'll build up the lining of the uterus. And if it grows and grows and doesn't have appropriate opposition from the progestogen, then it could develop into a uterine cancer. So in the WHI study, those without a uterus were given estrogen only, and there was not an increased risk for development of breast cancer in that group. In the combined synthetic estrogen-progestin group, there was a small increased risk. So,
and these risks were like 3 additional people out of 10,000.
Yeah, about 1 in 1,000 after 3 to 4 years of use, and that's on an annual basis.
So even if that was all legitimate stuff, which the findings were legitimate, but the study was probably a bit flawed. But looking at that, those numbers are still really, really low. I think that's the important thing, is that hormones were still generally very, very safe. But what we're learning is that early intervention is a better way to go, for sure, in preventing cardiovascular disease, and then at maybe mitigating the risk of additional breast cancer diagnoses, right?
And we do have a few studies out of Europe that have looked at bioidentical progesterone, and we do not see a notable increased risk for development of breast cancer. So the go-to options are the bioidentical estrogen, estradiol, and progesterone. And one thing that I do want to mention is that bioidentical doesn't necessarily mean it needs to be compounded. We have FDA-approved bioidentical hormones that you can get at your local pharmacy,
right?
And your insurance should cover. And those are kind of the go-to options.
So hormone therapy, is it a one-size-fits-all type of thing?
Absolutely not. We all have our unique special bodies, and my job is to go through and chat with you and figure out what works best for you. And find out the therapy that would work best to support you. And
that's one of the great things I think about bringing in naturopathic medicine, holistic health into a clinic like ours, is that sometimes the allopathic training that we were given as medical doctors really just kind of glossed over some of this stuff. It was a one-size-fits-all. Patient comes in, if they've got hot flashes, you give them this particular medication, and that was it. And that's definitely not what we hear from our patients. I think individualized care is really important, and then also considering things like personal wellness. I mean, there's got to be some dietary modifications and lifestyle changes. We do believe in this concept of you really are what you eat, and what you put in your body does make a difference, right?
So and your lifestyle habits and how you sleep, and those are some of our favorite things to talk about here.
Okay, so one other topic, and then we'll probably wrap this one up for at least this episode. And this is a big one. I want to talk a little bit about libido.
Yeah.
Okay, so women coming in, and this probably starts in the mid to late 30s, where whether it's because of stress or work or relationship strains, not spending enough time on things like connecting with your partner, we see patients coming in with complaints about libido. And I think that it's important to recognize that female sexual function is complex.
It is.
And it's
so
multifactorial, for sure. I think for the gentleman, and I can say this, it's probably maybe because our brains aren't as complex, I'm not sure, but it doesn't seem to be quite as complicated for guys. It usually is a lot of the men think it's a drop in testosterone. That can happen in women too.
Absolutely.
So a lot of women don't realize that they have testosterone.
Yep.
And testosterone is a hormone that is also made from the ovary, right? Yeah, so if you have your ovaries removed, you're going to potentially have a drop in testosterone. Another interesting thing that occurs with libido is being on combination birth control pills can also drop one's libido. And the way that happens is by actually increasing a protein in the blood that binds up sex hormones. So there's a lot of reasons why you might be experiencing decreased libido. And again, Dr. Conlin, Jade Carboy, myself, we really enjoy helping our patients, that are struggling with these sorts of things, because they do impact daily life.
Yeah.
What other things can we wrap up in the next 2 minutes here? Any good tips and tricks about, when should I make an appointment? Should it be in person? Should it be telehealth? How do I know if it's time to see Dr. Conlin?
Yeah, perfect. The last thing I do want to say is that hormones aren't for every single person. There are absolutely some cases where hormones are not the ideal, but you are not meant to just suffer through perimenopause and menopause. We have non-hormonal prescription options. We've got some evidence-based botanical options. So there are many different options to help support you. You do not have to go at this alone. So if you're feeling like you've got symptoms, or saying, one or two of those things that you listed, that sounds familiar, or you are full-blown in hot flash land and you want some help, you give us a call. And we are happy to see folks with telehealth. We're happy to see people in person.
And so you mentioned the botanical stuff. So if patients are interested in things like Dong Quai and Black Cohosh, and is that stuff?
We talk through all the research on it, benefits and risks of everything that we can do.
Great. Well, this has been awesome. If you have questions about really anything gynecologic, women's health related, you can Email us at info@pearlwomencenter.com. I believe you can find links on our website, and you're always welcome just to pick up the phone and give us a call and come on in for an appointment. We would love to see you. Thank you so much, Dr. Conlon. All right.
Happy to be here.